want them to get using the treatment technique you're using. So motor response is your indicator that we are doing this right. So when I'm doing endogenous opiate, motor response is the indicator that I'm doing something right. So that's why I want to see motor. When I'm doing sensory analgesia, I don't want motor. Because if I'm getting motor, it's too high and I'm overstimulating the sensory nerve. So I don't want motor for this. I want no motor. Strong sensory sensation, no motor. Here, I want motor. Here, strong sensory sensation, no motor. So the only time I want motor or to see active movement is when I'm doing endogenous opiate protocol, which I'm primarily using for, when do I use this? Chronic pain or what's the other thing we like it for? What have we been treating it with? Say it again, Miss Barbara. Trigger point. Thank you. Trigger point. Those are the two times I want to use endogenous opiate. If I'm dealing with chronic pain and or trigger points. That's my indicator. This is the protocol I'm choosing. That's my indicator. Okay, so we worked our way through that. We know how pain communicates information. We know how to set up stuff. We know how to surround it. We know how to find it. We know how to do all kinds of cool stuff. You have done really cool stuff with pain, whether you recognize it or not. Okay, so now we need to figure out how do we assess pain pre and post therapy. So pre and post therapy. So the objective is when we're treating patients for pain, we need to have some type of objective data. It can be some subjective as well, but it's great if we have subjective and objective data to validate what we've done has improved our patient's report. So insurance companies love objective data. Patients love subjective data. Oh, I feel so good. You're just amazing. Oh, it's amazing. I don't hurt anymore. But the insurance company wants something objective to prove that. How do we know you've moved them from miserable to good? How do we quantify that? So we have to figure out ways to quantify that. So it's good to have some subjective report where the patient is saying, I went from an 8 out of 10 when we started therapy. Now after therapy, I'm a 2. Great. But we need to have some methodology to quantify that. Okay. So page 20, the book talks to us about talks to us about 3, and we're going to add one more. Okay. So page 20, it talks about pain assessment. It says pain is a subjective experience. That's true. Kinda. So in that, put a question mark there. Pain is subjective. Kinda. Pain can be objectively quantified though, even though it's a subjective report. So there are some things that they called, I just had it in my mind. Come on here, Winston. It's not called work hardening. It's the thing you do before they put you in work hardening. FCEs, there we go. Functional capacity evaluations. So FCEs. So if you're a person who works and you're saying you had a work-related injury, I did something at work, I slipped and fell on a wet floor. Oh, my back, oh, I can't move, I can't breathe, oh, I'm dying, oh. So they can take your word on it that you're that miserable and you'll never be able to work again, or they need to get some objective measurements to prove what you're saying. So most times they're going to send you to a therapist, most likely these are done by PTs, and you will perform what's called an FCE, a functional capacity evaluation. I'm going to look up and see if I can find one on here. But during an FCE, they do all of these tests with you and they're looking for your response to certain things. So they may have you sitting upright without back support for 5 minutes. Then they may have you walking up and down a floor, just a straight floor. They may have you pushing a sled. They may have you climbing a ladder. They may have you doing repeated tasks of screwing in stuff where you're having to bend over and stand up. And so most people who do the FCE just think these are remedial tests and they're stupid. But what they're trying to do is get an objective measurement on what you're saying. True pain causes your blood pressure and your pulse rate to rise. You can test it. So we can put a monitor on your finger, like a pulse oximeter on your finger where you're at right now, and we could pinch the crap out of you. Your pulse is going to rise as you are in pain. Pulse rises when pain happens. Or with fear. Fear is another thing that'll raise your pulse. I'll never forget it. I was doing my physical to get into school, and I was laying there on the bed. I wasn't paying attention. I was in like a clinic, and I was waiting on the people to come in, and I'm just laying there in the clinic. I'm laying, and I think I dozed off and didn't recognize I dozed off, and I almost fell out. I fell off the little plinth that you're on. So it was a plinth like the ones we have back there, and I actually fell off the thing, and I hit the ground. Wah! And so right after I hit the ground, the lady walks in. Like, of course you'll walk in now. And she's taking my pulse. She was like, ooh, man, your pulse is high, it's racing. I was like, no, I just fell off the darn plinth. Take it later, it's gonna be a lot lower. You like literally just walked in from a traumatic event. I just fell. And so she took it again about 2 or 3 minutes later, and it went down. So things like that will raise your pulse. So if you're in acute pain, if you're saying activity makes me hurt, and they put you in an activity and your pulse or your blood pressure doesn't raise, that's an indicator that you're probably not telling the truth. So it's not exact, but it is something that they use to measure. And those are called functional capacity evaluations. Let me see if I can find one. And so they're all-day tests. They take about 4 hours. And, you know, the person has a right to do or not to do. They can reject doing it or they cannot do it. But it is the objective. So let's see here. So here we go.
In addition, Westarm offers specialized services to support your journey.
One of the tools we offer is
So the functional capacity evaluation is a standardized test looking at the variety of force demands and movement and position demands that are common with work as it's done today in the United States and across the world. The intention with these tests is to paint a picture of an individual's safe workability. That is the intention. So a lot has to happen in order to capture that information in a way that will be considered valid, consistent, and reliable. So the functional capacity evaluation.
Whether you're recovering from an injury or managing chronic condition, Westarm offers specialized services to support your journey.
One of the tools we offer is our Functional Capacity Evaluation, or FCE. This comprehensive assessment helps determine your physical abilities and limitations in a safe, controlled environment. FCEs evaluate how well you perform tasks essential to your work activities, giving you, your doctor, and your employer the information needed to make informed decisions about your care and return to work. From lifting and carrying to endurance and balance, we assess every aspect of your physical capabilities. The goal? To ensure you're ready for whatever comes next in your life or career.
This isn't to say that every patient is faking and everybody believes every patient is making it up when they say they're in pain. You're trying to see on a scale of disability what they're actually able to perform. And that will determine what will happen next. We as therapists don't determine what happens next. That's determined above our head at the physician level. All we do is write a report of what the patient is able to perform, was not able to perform, what were the results of those with their heart rate, their blood pressure, what were the results of those in their pain reports, what did they say? So we're doing subjective, objective data for 4 hours, pulling together assessments, and we send that to the physician. The physician then summarizes that and says, based on what we are seeing, you are capable of going back to work at this type of work level that you were at. You're not capable, but you will need these type of interventions. You may need therapy, you may need surgery, you may need work hardening, where they bring you into a therapy facility and they literally put you through 8 hours of work activity all day long. So you show up at therapy like you show up for work, and they have 8 hours of stuff that they put you through all day. So they may have you going up and down a ladder for 20 minutes. They may have you doing sled pulls for 20 minutes. They may have you doing box jumps for 20 minutes. They may have you going up and down stairs for 20 minutes. And you take a little bit of a rest break and you go right back at it. And you're doing that for 7 to 8 hours a day in a therapy facility with someone monitoring you. So that's called work hardening. So they may do that. We'll see. Or they may say you need a change of position. What you're doing is too strenuous for what your body can tolerate at this moment. You need to, they need to either pay you out or and help you find something else, relocate you in the facility, or you're unable to work altogether, and now you may qualify for disability aspects. Now, disability, a lot of people get disability confused and go, people just getting over on the system. Disability is something you pay for. Let me help you with that. You are paying for disability already. How many of you work right now? Anybody with a W-2 based job? Good stuff. How many of you have had jobs before? It's good stuff. So you've gotten a paycheck. If you look on your paycheck, back in my day on our paycheck, it used to be called FICA. Remember, anybody, do they still use FICA as a word that's on there? FICA. So if you look at FICA, what FICA is insurance. So you're paying for Social Security, you're paying that in advance. So you're paying for your Social Security in advance. That's a retirement program the government has mandated you pay into so that you have some money coming in after you retire when you get older. So in case you don't budget your money, the government will help budget it for you. So that's Social Security. That's one thing that's paid from FICA. The other thing that's paid from FICA is Medicare. The federal government says we're going to make sure that you are prepaying for health care when you get old so that you don't have to worry as much. It's not as good as it used to be, but it's still something. So you're prepaying your Medicare. And the third thing you're paying is for disability insurance. If you're ever injured on a job and can't go back to work, then you prepay disability insurance. So you paid for that. So don't let people lie to you like, oh, these people getting over on the government. And there probably is some people that's doing that. I don't know. I'm not in everybody's situation. But do know that money is not coming from the government. That's not coming out of your tax dollars. You prepaid that on the front end when you went to work. So that's why you have to qualify for it. So, but you do prepay a large portion of that when you go to work and through your payroll taxes. So just good information in case you didn't know that. Some people like, oh, I knew that. Some people like, I just heard that the first time. I didn't know that. Yeah, so that's what FICA is. So as much as people hate FICA, that's why you pay it, because it's prepaying stuff in advance. Okay, so how did I get here? What was I talking about? Pain. Pain being objective and subjective. That's where this whole off the rail thing went. Pain, mostly subjective, can be objective in its report, but it can sometimes be difficult to measure. It says it's essential to have some means of monitoring pain, the perception of pain at any given time. That's what we want to do. So some objective things we can do are things like the McGill Pain Questionnaire. So that is a questionnaire. Even though it is a questionnaire, it does give us some objective data because it's scored. visual analog pain scales, that's subjective. That's where the patient is reporting to you their pain scale. And so we've talked about these visual analog pain scales in the first semester. Some of them will have the Wong-Baker Faces pain scale built into them. So that's a visual analog scale there. And they can just rate, so they can go in and either put the number or put the line where they want the line to be. So if they put it in the middle, it's about, 50% pain, 75%, 100%. And so sometimes we'll do visual analog with words so that people can have wording to go with it. And then we do visual analogs with the Wong-Baker Faces pain scale. And that's always good. Remember, we talked about why we like Wong-Baker, because it allows for us to document inconsistencies. That's a great word for you to stick in your memory and never forget it, and use it when you're documenting. We can't say a patient is faking. That's not our job. But we can say a patient demonstrates inconsistencies. Now, who in here, Jaden is a great example. What number of pain you felt like you got on the pain scale, sir? He just had a root canal Friday. You got up to about a 7. Okay, so at a 7, were you jumping up, high-fiving people, shaking hands, smiling, happy to be there? Man, it's the greatest thing that ever happened in my life. That didn't fit. Those two things, 7 out of 10 pain and happy, joyous, woohoo, high five, don't fit together, do they? So if he told me he was a 7 out of 10, but he was high-fiving people and walking in and nothing looked like it was wrong with him, that is inconsistent. Do we agree? Doesn't fit. So Wong-Baker Faces pain scale gives us the ability to document inconsistencies. So my patient may be reporting 10 out of 10 here. They're saying they're here. But in functionality, they look like they're a 0. Now, that's not my job to determine what is what. My job is only to report what happened therapeutically. So if the physician writes back and goes, you didn't get my patient better, y'all are sorry such and such therapist. No. Go back and read my progress note. Your patient had these objective measurements. Their range of motion is normal. Their strength is normal. Their functional mobility is normal. The only thing that's abnormal is their pain report of 10 out of 10, but based on the Wong-Baker Faces pain scale, they came in every day with a facial expression of 0 out of 10. So whatever is going on is beyond therapy's ability to correct. That's how you manage your relationships with physicians if they're having to refer you patients. You're not going to go back at you sorry such and such doctor. If you did your freaking job, this wouldn't be a problem. Sometimes you think that, but you can't say that out loud. But what you really are doing is managing truthfully what's going on with the patient. And so a lot of times PTA, you will be with the patient 5 straight visits before the PT sees them again. So that's what we call the 6th visit. We talked about that in the first semester. So you'll be with them 5 straight visits. So it's going to be incumbent on you to document stuff like this, because from your notes is where the PT is going to write their progress note or their discharge note. So whatever you're putting in the chart has a lot of weight. So don't feel like you're like, oh yeah, nobody reads my note. No, your notes are valuable. That's how people make synopsis and write progress notes or discharge notes. And that's what the physicians are reading. They're going to read those notes to figure out what's going on with the patient. So it's important that we have opportunities where we are using not just subjective reports, but we can add in things with subjective reports. So even though I am using a visual pain scale, I'm also adding in some objective data. So that's usually a visual analog. that we can add in, and it sometimes can have numbers with it, a numerical pain score. And so that's the one we do a lot of times therapeutically, is we use numerical pain rating, where the patient gives us a report. You know, I'm a 4 out of 10, I'm a 7 out of 10, I'm a 3 out of 10, I'm a 2 out of 10. So this is the most used one therapeutically, is we're asking them to self-report with a number. And so I always quantify 10 is the worst pain you've ever imagined in your life. And if I get a 10 out of 10 constant report person, then I have to give them exampling. So I go, you're a 10, I'm a 10. So this could get no worse, can't get any worse. So if I go to my car and get a chainsaw and chop this extremity off, it would hurt no more than you're hurting right now. Now I think it'll hurt worse then. Yeah, so you're probably not a 10. Let's peel that back off the wall. I know we feel like we're 10s, but let's peel that back. Or if you are a 10, let's figure out why. What the heck is making you a 10? Some people get to this number. That's a real thing. We need to know why. So when we're dealing with patients, again, we have the McGill pain questionnaire. That's objective. So this is what the McGill will look like. And so it's objectively scored. That's why we call it an objective data. It's used to evaluate a person's experience. Let me make this bigger so you can read that. There we go. That better? There, that better. There we go. Now we have something you can see there. Yep. So it's used to evaluate those who are experiencing significant pain. Can be used to monitor pain over time and determine the effectiveness of the intervention. Now, that's interesting. Who developed this? Dr. Melzick, the same person who came up with this gate control theory. So, Melzick of Melzick and Wall developed the McGill Pain Questionnaire. And so, these are the different sections of it. What does the pain feel like? 2, how does your pain change with time? 3, how strong is your pain? Okay, and so statement 1, some of the following words can be used to describe your pain. Circle only the ones that best describe it. Leave out any category that is not suitable. So, is the pain flickering, quivering, pulsing, throbbing, beating, or pounding? Is it jumping, flashing, shooting? Is it prickling, boring, drilling, stabbing, lancinating? So to lance something is like it's cutting you open. So you like to lance if they go in, you have some kind of a boil or something, they'll tell you they have to lance it. They have to cut it open. So that's what lancinating means. Is it sharp, cutting, or lacerating? Pinching, pressing, gnawing, cramping, crushing. So it's just going through different terminologies that go with their pain. And it's dealing with different areas of it. Autonomic, there's tension, fear, punishment, affective, evaluative, sensory, affective. There we go. Okay, how does your pain change with time? This is looking at, is it something that's altering? So that's what we want to know. Do the following things increase or decrease your pain? You want to know this. Okay, all of those. How strong is your pain? So that's why this is more objective. It's putting actual terminology just instead of what the patient's reporting. So here's the interpretation, because this is what is testable. So I don't want you to try to remember all these words. So don't feel like I want you to memorize the whole McGill Pain Questionnaire. That's not my job. I don't want you to try that. So minimum score could be 0. It says a patient who is not in true pain would never be a 0. 78 would be the maximum score. So 0, it should never have a 0 if a patient is reporting pain, and 78 is the maximum score. So if they're over 78, that makes you want to question what they're saying. Not saying that they're wrong, it just gives you pause and question. So 0 to 78 is about where we want to stay, somewhere in that range, 0 to 78. What, not 1 to 78, excuse me, 1 to 78 for a patient in pain. They should be at least a 1, no higher than a 78. So 1 to 78. They shouldn't be a 0, and they shouldn't be over 78. And it has been tested for reliability and validity, meaning we talked about reliability and validity in PTA 1911. Something's reliable means you get consistent results. If it's valid, that means it's been shown to measure what it's supposed to measure. So that's the McGill Pain Questionnaire. And so the book tells us under that, it says the McGill Pain Questionnaire is made up of several parts and attempts to measure the patient's perception of pain. Body diagrams for pain location and word descriptors are included. So the one we pulled didn't have the body diagram, but sometimes they will. The patient description of pain intensity and pattern related to activity compose the remainder. The advantages, now this is the main part that you want to know. The advantages of using it include collecting quantitative and qualitative data. So quantitative means we have objective data, numerical objective data. Qualitative is also can be objective, but it's usually more patient report kind of things. But quantitative is objective numerical data. And that, goodness, that's loud. Sorry about that. And that helps us to have, as the book tells us, information regarding pain and providing information on the effects of different treatments. So you would do this at intervals. This is not something you do with every treatment. It would be good if you have a patient with a high pain report, have them do this on the first day. If the PT didn't have them do it the first day they saw them, maybe before you get them started, while if they show up early, that's excellent. That's a good time to have them fill this out, give them some directions. If they need help reading it, you may have someone to help them read it, a tech that works there or something, and they can fill this out. So you can have some subjective and objective data for both of you. And then as treatment progresses, after a 2-week interval, it would be good to have a follow-up, definitely after a month. Usually progress notes are written every month, every 30 days. So you want one for sure every 30 days to know how the treatment is progressing with that patient. It's good to have. The McGill Pain Questionnaire. I'm trying to print you a copy of it so you'll have it. But of course the printer is acting like a clown for some reason. No clue why. And this printer here, this computer here is not connected to the printer, so I'm going to have to print it from my office, which I'll do once we take a break. Okay, so visual analog, we showed you that one, and it talks about that. It says, although not as sensitive as the McGill, the VAS is a quick means by which they can rate their pain. The patient is given a piece of paper marked with a line that is 10 centimeters long. So that's what you want to highlight there. So visual analog will be a 10 centimeter line. At one end is written, worst pain I've ever felt. The other end, no pain at all. They're asked to mark on the line the point corresponding to their pain. And then the records can be kept to position. So you give them a different VAS every day they come in, instead of just taking a number. If their numbers are way out of whack all the time, I'm a 10, I'm a 74, I'm a 12, I'm a 13, I'm a 99, this isn't calling out football numbers. Give me a dadgum number. Lock in, give me a number. I need to know exactly what you are today. So VAS is good for those patients. Numerical pain rating, that's the one we talked about. It's a variation. They can be asked to rate it. 0 out of 10, 10 be the worst pain imaginable, and then you can keep that number. So you can do a VAS and a numerical pain score on a daily basis. And remember the Wong-Baker pain faces scale. Now it's printing for some odd reason, which I don't understand. We'll see. We'll see what prints. Okay, so those are 3 that we talked about There's one other one, the Oswald tree, low back pain disability questionnaire. So usually this one is specific to low backs. So you're not going to have this on every patient. But for those people who have low back pain, which according to Robin McKenzie is probably 30 to 40% of your patients will have something going on with back or neck. So a lot of people will have back pain. So it's a relevant one. But the Oswald tree is for low back pain. It has interpretation of scores, different sections on it. So there are 10 sections that are on the Oswald tree. I'll try to print this out. It says scoring instructions. This is just good to know. For each section, the total possible score is a 5. Hang on, let me make this bigger so you can read that. I don't want you trying to strain your eyes. I can't afford to buy you glasses. There we go. Nope, I gotta pull it down one. Okay. Yeah. Okay. Yeah, so it's good for disability evaluations for patients. Each section has a total score of 5. The first statement is marked. If the first statement is marked, the section score is 0. If the last statement is marked, they get a 5. If all 10 sections are completed, the score is calculated as following: 16 total score, 50 possible points, times 100, and then that gives you a score. If one section is missing, then that gives you a score. And then they give you a different levels of disability. So this is kind of what I'm interested in you understanding about it. You don't have to, you have to memorize all of this. 0 to 20% on it, minimal disability, 21 to 40, moderate, 41 to 60, severe, 61 to 80, they call it cripple, and then 81 to 100, bedbound, or exaggeration of symptoms. So that's how we would score the Oswald tree. And here are the sections in case you're wondering. Section 1 is pain intensity. 0 for I have none. 5 is this one, pain worse than imaginable. Section 2, personal care, washing, dressing. So that's dealing with ADLs. I can look after myself. I do not get dressed. I wash with difficulty or I stay in bed. 3, lifting is the next one. Either I lift heavy weight or I can't carry anything. 4 is walking. Pain does not prevent it. I'm at bed most of the time. 5, sitting. 6, standing. 7, sleeping. 8, sexual life. Sometimes you're going to have to ask those questions, so be comfortable with uncomfortable. 9, social life. 10, traveling. Okay. All right. Okay. So that's the Oswald tree. So it's 10 sections, and specifically, those are the interpretations. Okay. All right, so those are the 4 pain scales we wanted to cover of how we would assess pain. Visual analog pain scale, sometimes it can come with the Wong-Baker. We either don't show them the Wong-Baker. You don't want them to see the Wong-Baker. That's something you have for your records. But visual analog pain scale, numerical pain, then we have the 2 objective data, the McGill and the Oswald tree. So 2 subjective, 2 objective. 2 subjective, 2 objective. All righty. So it's a good place to take 10, let your brains cool off. Sure. Yeah, there you go. And I'll put those back. I'll put that on the thing so y'all can have these. I'm gonna try to get you a printed copy. All right, so let's take 10. It's 10 after. We'll come back at about 9:20. And we'll pick up on the last part, and then we'll have some fun.